Top Med Talk.
Nick Harrison here. Welcome to Top Med Talk. This piece is taken from the Perioperative Medicine Shared Interest Group's 2018 annual conference, Measuring, Managing and Minimising Risk, which was held in association with the Australian and New Zealand Society of Geriatric Medicine and the Internal Medicine Society of Australia and New Zealand. Don't forget to check out the show notes on topmedtalk.com for more details. Have a listen.
Thank you, Christina and Vasi. I'm now going to invite Associate Professor Harry Gibbs up, who's going to talk to us about antiplatelets and novel anticoagulant agents. Harry Gibbs graduated from Sydney. He then went and worked in Brisbane, but is currently the Program Director of Outpatients and Deputy Director of General Medicine at the Alfred and at Sandringham Hospital here in Melbourne. And he's an Associate Professor of Medicine at Monash University. Can I ask you to welcome Harry Gibbs?
Thanks very much. Thanks also to the organisers for inviting me to present today. And I wanted to frame my presentation within the context of the magnitude of this issue. And for those who are interested in the big picture of health, I can recommend the Lancet from October 2016 as a very good read where the results of the Global Burden of Disease study are published. And if we look at the effect of three important conditions associated with thrombotic complications, namely myocardial infarction, atrial fibrillation and stroke, they accounted for about 15.5 million deaths in the world during 2015, which is about a third of, or a little under a third of all the deaths in the world in that year. And there are about 187 million people living with those conditions. But of course, this is an underestimate of the greater burden of thrombotic problems because it doesn't take into account other conditions such as venous thromboembolism, which were, for some reason, not reported in that study. And with due respect to our first speaker, this is, in fact, about double the mortality and the prevalence of all cancers lumped together. And at about the same time, there were 232 million operations performed in the world. And presumably some of those were of benefit to the patient. But what that means is that thrombotic conditions and surgery frequently collide. So thrombosis is clearly the commonest cause of death and disability worldwide. Antithrombotic therapy is extremely beneficial. So there's a reduction of mortality of about 25% with the use of oral anticoagulants in patients with atrial fibrillation. There's a reduction of mortality of about 25% in the management of patients with acute pulmonary embolism with anticoagulation. And there's also a reduction of mortality of about 25% by simply administering aspirin at the beginning of an acute ST elevation myocardial infarct. So these are incredibly effective therapies, but come with the cost of some bleeding. And bleeding, of course, is problematic in patients undergoing surgery. Surgery, as I've mentioned, is extremely common, and bleeding complications are bad in surgery, as I'll discuss. But surgery promotes thrombosis. So getting the balance of anticoagulant therapy right in patients with a requirement for that treatment is extremely common and extremely important in perioperative medicine. This is, I think, a fantastic image of a thrombus. So it's a colorized EM. And you can see there red blood cells, which are red. There's a white blood cell, which for some reason is green. And then there are a whole lot of platelets which have lost their usual plate-like shape and have become very irregular as they've become activated and are extruding various vasoactive and hemostatic compounds. And the whole thing's held together by a fibrin mesh in orange. And this reminds us of the two basic pharmacological approaches to reducing thrombosis, and that is to reduce platelet activation or to reduce fibrin generation. and I'm going to discuss the management of patients who require those therapies. Now, for those of you who've been out enjoying Melbourne's nightlife or have sleep apnea or something and are feeling a little somnolent, just have a quick look at this slide and then you can have a snooze for the next 20 minutes. And just trust me that I'm going to justify some of these broad statements. I'm going to discuss the fact that the thrombotic risk for most patients undergoing surgery is less than you think. Bleeding is very bad. The need for bridging anticoagulation in most patients is infrequent and probably overperformed, and you can keep going with aspirin. So I've broken my talk into two components. The first looks at patients undergoing elective surgery, and the second is at those undergoing emergency surgery. So for those undergoing elective surgery, the first thing that you need to do is to make some assessment of the patient's bleeding risk and of the consequences of bleeding. Bearing in mind that a mil of haematoma in the thigh has very different consequences to a mil of haematoma in your brain or in your spinal cord, so that the consequences are extremely important. And there are really surgical factors that predict bleeding, and then there are patient factors. If we look firstly at some of the common surgical procedures where there is a very low risk of bleeding, that would include dental extractions, cardiac device implantation, cataract surgery, and diagnostic laparoscopy. And there's a very good and very complete list of surgical procedure bleeding risks, which you can find at that website there. So it's the Journal of the American College of Cardiology, and they've got a consensus statement on managing anticoagulants in the perioperative period. And in their appendix, there's an excellent list of pretty much any surgical procedure you could imagine, which has come, and the bleeding risk associated with those procedures, which has been developed through a consensus process by the various North American surgical societies. So, the Gynecological Society has all their gynae procedures there and so on. So I'd recommend that to you. Patient risk factor the assessment of patient factors is actually quite difficult to do, and we don't have very good validated methods of doing that. However, there are some factors that do predict bleeding, and probably the most important is prior bleeding, particularly if that's occurred during some procedure. A very important thing to be aware of. Advanced age, liver and kidney dysfunction, and abnormal platelet function are also important predictors of bleeding. And again, the article that I've just mentioned has a fairly extensive list of potential risk factors for bleeding. There have been some scoring systems, and one that's frequently used is the HAS-BLED score. I think it's worth noting that HAS-BLED was derived and validated in patients receiving vitamin K antagonist therapy for stroke prevention in atrial fibrillation, and it has no validation for patients undergoing surgery, and it doesn't perform all that well. It doesn't have a great C statistic in the in any case. So whilst some authors do suggest considering the HAS-BLED score, I think it's got many limitations and don't use it. So if you've made this assessment and have determined that a patient is at a low risk of bleeding and that the consequences of bleeding are not likely to be severe, then you should simply continue all antithrombotic therapy and do the procedure. So that's easy, but relatively infrequent. So what about if the bleeding risk is not low? And probably most of the audience here who are going to be involved in larger procedures, really, where there is going to be a significant bleeding risk, it means that you're going to have to discontinue anticoagulant therapy. So, if you're going to have to discontinue anticoagulant therapy, which you will do for pretty much any decent-sized operation, then you need to, if the patient is receiving an oral anticoagulant, make a couple of decisions. And the first is, if they're receiving a vitamin K antagonist, then you have to decide whether you're going to bridge the patient with some alternative anticoagulant, and that would normally be a heparin. If the patient is receiving a NOAC, and so I'm a cardiologist, so we call them NOACs, the haematologists call them DOACs, but there are more cardiologists than haematologists, so I'm sticking with NOAC here, as in non-vitamin K antagonist oral anticoagulant. And so if a patient's on a NOAC, really there's, I think, virtually no time in which bridging is going to be required, because NOACs have almost exactly the same pharmacokinetic properties as the agent which is most commonly used to bridge, which is a low molecular weight heparin. So you're simply substituting one thing for something which is exactly the same. And really the key to all this is just getting the timing right for the discontinuation of the drug so that there's no anticoagulant effect when the surgeon begins their incision. So let's focus firstly, however, on the vitamin K antagonist patient to see whether bridging is required. And routine bridging has been studied fairly extensively now, and there are actually quite a number of meta-analyses, but I've just taken this fairly recent one here to show you because it's quite extensive, looking at 25 studies. I think 8 or 9 of those were RCTs and the remainder were observational studies, and it looks at nearly 36,000 patients undergoing undergoing surgical procedures with or without perioperative bridging. And if we look firstly at bleeding, those who have perioperative bridging therapy have more bleeding. They've got about a 3-fold increase in both major bleeding and in overall bleeding. So bridging leads to bleeding. However, there's no reduction in thromboembolism or in mortality. So all you get are more bleeds and you don't get any gain. So that's routine bridging. Having said that, there are a certain subgroup of patients in whom there probably is a very high procedural thrombotic risk, and there's consensus but no strong data that these patients should undergo peri-procedural bridging, and it's reasonable, I think, to consider it in the small subset of patients. So those who have atrial fibrillation with a very high stroke risk, and that would include those with severe mitral stenosis who have atrial fibrillation, those with a very high CHADS-VAS score, or those who have had stroke or systemic embolism within the previous 3 months. Patients who have had recent acute venous thromboembolism, again within the previous 3 months, should be considered for bridging, although they're also a group in who you could consider an IVC filter. And patients, the general feeling is that patients who have a mechanical heart valve who are receiving warfarin therapy should have bridging therapy. The exception to that are the group of patients who have a bileaflet mechanical aortic valve who have no other particular risk factor for stroke. The aortic valve is pretty forgiving in terms of thromboembolism, actually, so that's a group of patients who you can probably get away with no bridging. So if you are forced into bridging, then There are a couple of ways of doing it, but basically you stop the vitamin K antagonist 5 days before the procedure, and then start low molecular weight heparin or a heparin infusion 3 days beforehand, or when the INR drops below 2, and then you stop the anticoagulants leading up to the surgery, so that there's no anticoagulant effect at the time of surgery, and that usually means stopping low molecular weight heparins 24 hours preoperatively, and a heparin infusion 4 to 6 hours preoperatively. So most patients, however, just simply require cessation of the oral anticoagulant, but no bridging, and we overbridge, so don't overbridge. And so if you're going to simply stop, then if it's warfarin, you stop 5 days preoperatively, or I think Kate Burberry presented yesterday, and she's got some very good data and compelling evidence that the administration of parenteral vitamin K about 18 hours before the procedure will have most patients back to normal coagulation at the time of the procedure, and that's a very good option. If the patient's receiving a NOAC, then there's actually not a great deal of anticoagulant effect 24 hours later, but normally we recommend discontinuing 48 hours beforehand. But these agents are renally excreted, and in particular Dabigatran is predominantly renally excreted. So if a patient has renal impairment and is receiving one of the NOACs, and in particular, again, Dabigatran, or if you have an extremely nervous surgeon, or if you're an extremely nervous anaesthetist for that matter, or the consequences of bleeding are very significant, so with neurosurgery, then you might want to stop 72 hours before the procedure. So is there any value in doing coagulation tests? Being a physician, we like to test things a lot, but there's not really much value in doing it. I guess most patients who've been on warfarin will have an INR, and that's pretty reasonable. If a patient's been on a NOAC, there are specific tests that will tell you whether there's any effect of the NOAC present. And for Dabigatran, you need to do a dilute thrombin clotting time. And for rivaroxaban and apixaban, a 10A level, which has been calibrated according to which of those two drugs the patient is receiving. These, if they're normal, mean that the patient has no anticoagulant effect. If they're prolonged, then it doesn't really tell you what the hemostatic defect is in the same way an INR gives you an idea about what the bleeding risk is. It just tells you there's some effect there. So it can be a bit confusing to actually do the test in the first place. So after the procedure, use VTE prophylaxis as required, and that probably gives you a bit of arterial antithrombotic effect as well, and then start the oral anticoagulant when the bleeding risk is low. So because warfarin takes a few days to kick in, you normally start warfarin the next day, and NOACs you wait for a couple of days. And it's really important, I think, to talk to the surgeon about this, because sometimes they say hemostasis was fantastic, dry as a chip at the end of the operation, and sometimes they say everything was oozing a bit, and I think that's a very important piece of information that you need to have when you determine at which point you re-anticoagulate, because if you're starting a NOAC, remember they're fully anticoagulated an hour and a half later. So you don't want to do that until there is secure hemostasis. So what is the risk of interrupting oral anticoagulants? And there have been a number of studies that have looked at this, and it's lower than you think. So everyone always thinks the patient's going to have a stroke or something, but in fact, in this particular systematic review of patients interrupting NOAC therapy, the thrombosis rate in the perioperative period was less than 0.5%. And in the Bridge trial, which was a group of patients, looked at a group of patients with atrial fibrillation undergoing surgery who are randomised to bridging or not, again, the risk of arterial thromboembolism was less than 0.5%, both in the bridged and in the non-bridged arms. So it's lower than you think. And bleeding is bad. So if you're too aggressive with anticoagulants, you will lead to bleeding. And many studies have shown that bleeding is associated with thrombosis. So if you make a patient bleed, they're far more likely to have a thrombotic event. And there are probably a whole lot of reasons why that's the case, but once they bleed, you've got to stop anticoagulants for a much longer period of time than you would have had to do otherwise. And then you often have to do extra things to them, drain the hematoma, reoperate to suture up something and all that stuff. And patients are very immobile. So for all of those reasons, thrombosis is increased. So you're better off being less aggressive with bridging and early recommencement of anticoagulants, waiting a little time, bearing in mind that the risk of a thrombotic event is pretty low, and just easing back into the anticoagulation when it's safe to do so. What about antiplatelet agents? So for elective surgery, there's a little conflicting data around aspirin. Some studies show an increase in major bleeding, but not all. But continuing aspirin doesn't seem to have much effect on thrombosis. The biggest data set that we have comes from the POISE-2 trial, where patients with a cardiovascular risk who were undergoing non-cardiac surgery were allocated, if they were on aspirin, to continue it or not, and if they were not on aspirin, allocated to commence it or not. And in the group who were already taking aspirin, those who continued with it had no increase in bleeding compared to those who stopped, but there was no difference in thrombosis. So the general feeling is that you probably want to continue aspirin in a patient who's on it, and that seems to be safe, except where there are very high risks of bleeding, and in particular that's the case with neurosurgery, and also the prostate, somewhat pesky organ, tends to bleed a lot in patients who have had aspirin, so you probably want to try and stop it there. Dual antiplatelet therapy, of course, is most commonly used for patients with acute coronary syndromes, and particularly those with a coronary stent. So they are a much higher risk group, both because of their need for the dual antiplatelets, the underlying reason for that, and also because dual antiplatelets clearly have more bleeding than aspirin alone. The risk of bleeding is certainly highest early after a stent placement or acute coronary syndrome, and you're really best off if it's elective surgery to get the surgeon to wait and delay. But if you can't either delay or convince the surgeon to do so, then the best approach is to continue aspirin but stop the second antiplatelet. And the European Society of Cardiology have a very good consensus guideline, which you can find at the European Heart Journal, and they suggest that you should try and make some assessment of the cardiac risk, so low or high, depending on whether it was the stent was put in for an acute coronary syndrome, which makes it a higher risk, versus stable coronary disease, where stents don't work anyway, but they often get put in. So, in fact, the two, whilst they make this distinction between high and low risk, their recommendations are pretty similar, in fact, for both of these groups, and that is that you really don't want to do anything in the first month, and after 6 months you can stop the second antiplatelet and just continue with aspirin, and between 1 and 6 months you're best off really not to do anything, but if you have to, you can, but best not to. And this tells you when to stop the second antiplatelet agent preoperatively, and clopidogrel and prasugrel you stop sort of 5 to 7 days beforehand, ticagrelor about 3 days, and you keep aspirin going. This is taking into account the fact that platelets turn over pretty quickly, so as soon as you stop one of these agents, which they have very short half-lives, they've got long biological half-lives but short plasma half-lives, then you're starting to regenerate platelets pretty quickly. And for those patients, for example, who have ITP, they turn over platelets extremely quickly. So you've got a new set of platelets about 2 days later, so you could actually stop it sooner. But anyway, that's an aside. So let's turn then to emergency surgery. And the first thing to do if you have a patient who really needs emergency surgery is try and work out whether there's any anticoagulant effect present. And I've told you what tests to do. Here they are again. Vitamin K Antagonists do an INR, Dabigatran, dilute thrombin clotting time, and the 10A inhibitors, you do a 10A level. And you can be assured, as I've mentioned, that if these tests are normal, there's no anticoagulant effect. The patient maybe hasn't been taking their tablets. But if the tests, and I think you all understand how to interpret an INR, but if the tests for the NOACs are abnormal, it doesn't tell you whether the patient's going to bleed. It just tells you there's some effect. It might be a little bit, might be a lot, but it doesn't give you the same sort of information that an INR does, but it means there's some effect there. I think you all know what to do if a patient's been taking warfarin, that is you reverse it, and if you want to reverse it immediately, you do that with a prothrombin complex concentrate, which turns off the effect of warfarin within an hour. If you've got 6 hours to wait, you're beginning to get reversal by that time if you use vitamin K, and sometimes you might use both. For the NOACs, there is now a monoclonal antibody against Dabigatran, which is idarosuzumab, and this is incredibly effective. So the panel on the right of this slide comes from the pivotal study looking at idarosuzumab in this situation, and you can see that before the, you can see what the concentration is before administration, and then it's just gone immediately. This stuff just mops up Dabigatran and it's gone, and it's available in, I think, probably most big centres now, and probably many of you have experience using it. There is also a reversal agent for the 10A inhibitors, which is andexanet alpha. It also turns off the 10A inhibitors, so rivaroxaban and apixaban, and actually also enoxaparin for the first time, if we ever get this drug, will be able to be reversed. And everyone sort of gets worried about rivaroxaban, but we've been using enoxaparin for 30 years, and exactly the same arguments about irreversibility came out when it first became available, and everyone's sort of forgotten that and quite comfortable managing patients who've been receiving it. Anyway, andexanet turns off 10A inhibitors pretty quickly, but rivaroxaban and apixaban have a pretty wide volume of distribution, and andexanet is simply within the circulation. So as the riva and apixaban tend to wash back into the circulation, you get a bump in their levels a little down the track, as you can see from these two graphs. So whether that turns into subsequent bleeding is a bit uncertain, but you just need to bear that in mind. Although you don't need to bear it in mind because we don't have it in this country, and it doesn't look like we're going to be getting it in the near future because the North American and European markets are getting the what is available, and it's apparently difficult to make, and the company who make it have only got a small factory, so we're well down the list. So with that, bearing that in mind, if you do have a patient who's receiving rivaroxaban or apixaban, then there are some options, and that is to, again, administer prothrombin complex concentrates, which anecdotally seem to reduce bleeding in this situation. Might as well toss a bit of tranexamic acid in, and if a patient's bleeding to death, then you can give them some Novo 7. And finally, for emergency surgery, if patients have been receiving antiplatelet agents and are bleeding, you give them platelets. So, thank you for your attention, and for those who did have that little snooze, there has been stuff in between time. It's not just the same slide. So thanks.
Lee Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.